Yeah, thank you for introduction. Adults with congenital heart disease. It's compared to coronary heart disease, a small cohort, but the number of problems you may face with this kind of patients is much more than in any other field. And in my talk, I want to highlight only some problems. It doesn't work. In this talk, I can only highlight a few of these problems. I will give you a short introduction. I will highlight the fate of this congenital heart disease adults. One major topic is in this patient pulmonary vascular resistance. I will give you a case study presentation which troubled us in Hamburg for several months, a case after pregnancy. Fontan circulation, some words of caution to this patient. One hint to transposition of great arteries and considerations about tricuspid valve. Right heart problems are very common in congenital heart disease. And finally, the conclusions. Adult congenital heart disease is the number of patients is rapidly growing. This time in the industrialist countries, we face more adult patients with congenital heart disease than compared to children beyond 16 years old. And even in our countries, at least a quarter of these patients is not in specialized follow-up, maybe up to 50% in other countries. But if you look to this cohort of patients and and analyze how often they are in hospital, you see that hospitalization rates are 2 to 3 times higher than in the general population, particularly in the older ones beyond 40 years old. And the vast majority of deaths are cardiac and related to the congenital heart disease. We face to a lot of problems in the field of arrhythmias due to scar tissue, hemodynamics problems, and problems with a sinus node transduction system. Some patients have residual defects after surgery, multi-organ comorbidities, and lifetime some degree of heart failure, which is increasing with age. If you look to this analysis, which was recently published, you see that causes of death for CHD patients are especially in the more complex diseases like tetralogy of Fallot, TGA, hypoplastic left heart syndrome located. And if you make a sub-analysis to the CHD-related deaths, you see on the lower figure, the red bars to the right, there is some considerable risk if you go for re-intervention or re-operation for these patients. And one of the problems you face with all patients who had any kind of left to right shunt is a problem with a pulmonary vascular resistance. In this register study from Netherlands, you can see that even in simple defects like ASD, VSD, PDA, which were corrected timely, you have a higher risk for pulmonary hypertension when compared to the general adult population. And you have to face and treat the problem with the same recommendations like done for other patients with pulmonary hypertension. And treatment is also the same. The three pathways you have, nitric oxide, endothelin pathway, and prostacyclin pathway, if you diagnose pulmonary hypertension due to formerly shunting. And in patients where pulmonary pressure is suprasystemic, you might need strategies for decompression of the pulmonary hypertension. The possibilities we have is atrial but this is not decompressing, this is shifting volume to the other side of the heart. But you can also do, in some patients, you have maybe a small persistent ductus arteriosus brutalis, so you can establish a POTS-like circulation if you stent this duct, or you go for real surgical POTS shunt or transcatheter POTS shunt. Transcatheter POTS shunt is possible and recently published from several groups worldwide. It's a tight relation between the left pulmonary artery and the descending aorta. You see in the photo links on the left side down. And in this case, there was the aorta punctured in two directions to the left pulmonary artery, and the wire was snared, and then a stent implanted in between the two vessels, and so you can have decompression for suprasystemic pulmonary pressures. The next problem I would like to raise up is the tetralogy of Fallot. We know that the long-term outcome is not bad, but you see in the upper curve that in the long term, with 20, 30, 40 years, there is additional mortality, and the reason is that we have to face with different problems in the right outflow tract of these patients. 30% of these patients may need additional interventions during life, and it's always a question in between residual stenosis or a significant pulmonary regurg in these patients. And we have still, until now, no hard criteria when to intervene for pulmonary regurgitation. One publication from 2006 presented us data, and I think most working groups are looking to these values that, for example, an end diastolic volume of 116 milliliters of the right ventricle is the limit at which you should go to a pulmonary valve intervention. But I know many working groups going for lower limits, 150, some 150, 40 milliliters. You have always to consider normal volume of the right ventricle is around about 70 milliliters per square meter. And we had in 2015 a pregnancy after tetralogy of Fallot. What we knew from another outpatient service in which where the patient was treated, that she had a Waterstone's shunt 1 year after birth, and Fallot tetralogy was corrected at age of 7. So maybe this patient had some kind of overflow to the pulmonary arteries initially, but no medical reports were available for this patient. 7 years before she got pregnant, there was a catheterization in an adult cardiac unit, and the mean pressure was 22 millimeters of mercury. But then there was no follow-up for the last 7 years, and pregnancy was allowed by this cardiologist. And then, during pregnancy, she deteriorated more and more, And what we saw when she came in the 26th week of pregnancy was the pulmonary pressure, at least 80 to 90 millimeters of mercury derived from echocardiography. And we saw a very severe regurgitation of the pulmonic valve. She was treated with diuretics, and in the 32nd week, the pregnancy had to be finished by cesarean delivery because of placental insufficiency. And then we had a course inside the clinics of several months. She had still high pressure, pulmonary pressure. She had a left and right heart problem at this time, so that we speculated that we had a type 1 and 2 pulmonary hypertension, left and right heart failure, and severe pulmonary regurg. She was listed for heart-lung transplantation at this time, and we decided 2 weeks after delivery for a bailout procedure and went for a pulmonary valve replacement in our hybrid OR. And we put in a 29 millimeter Sapien valve. The cines are not working, I think. But on the left side, you see the placement of the valve into a understand landing zone, and the right video would have shown that there is no insufficiency after placing the valve. But after this procedure, it needed 4 to 6 weeks to wean the patient from the intensive care ward, so it was a hard course. And what I want to say is that if we would have changed this valve before pregnancy, maybe the course would have been very much easier for this patient. So some words for Fontan circulation. Is it success or failure? A paper raised this question some years ago, because with this kind of operation, univentricular repair, we have a long-terming venous hypertension and always a degree of arterial hypotension in these patients. And for sure, we have to deal with two different anatomies. It's essential to be aware that we are dealing with patients who have a left systemic ventricle, and we have patients who have a right systemic ventricle for this Fontan circulation. And if you compare patients, these are two of our outpatient service. One had a tricuspid atresia, so left systemic ventricle. Other one is hypoplastic left heart syndrome, so right ventricle. Both had a lot of surgeries and interventions, but this one with a left ventricle can go for biking, fitness studio, skiing. The other patient with a right ventricle has protein-losing enteropathy for 10 years now, no sports. At exercise testing, 3.5 watts per second, 36 milliliters oxygen intake. The other one, 1.5 and only 19 milliliters intake. So these are two different entities we deal with. And medication, the left one only aspirin, the other one 11 medications at this time. And for Fontan circulation, we always have to go for optimizing all pathways. One of the most frequent problems, at least in hypoplastic left heart this syndrome, is the reoccurrence of recoarctation. And second common is pulmonary artery problems. So, and sometimes in here is a Glenn situation, the atrial septal defect is too small. So we have to address everything inside the pathways which might cause resistance in the circulation. Here, a recanalization of a lost right pulmonary artery by stenting. Closing collaterals is also one option in failing Fontan situation. We have always to have a close look to the size of our Fontan tunnels. We have seen several failing Fontan situations where the surgeons placed the 18 or 20 millimeter extracardiac or intracardiac tunnel, and at the end you see something like this, 12, 13 millimeters only, and this may cause a failing Fontan situation. And this you may also overcome with stenting of the tunnel. So what is the longitudinal concept for this patient? It's rather not clear at this time. We have to look for conservative treatment of ventricular failure. You have always ventricular failure in this patient, especially the hypoplasts, and you have always a problem of pulmonary resistance. And this combination is very tricky in the long-term treatment. So what can we do? Several groups are looking for assist systems, but we don't know what is better, to assist the venous pathway or to assist the ventricle. One is the correct, the right point for listing for transplantation. 30% of patients after 25 years cause this discussion in every heart team worldwide. But if you wait too long, congestive hepatopathy and nephropathy will be a contraindication for transplantation. And if you see if patients come into protein-losing enteropathy, what means failing Fontan, the mortality is quite high, higher when compared to heart transplantation. So this we have to consider in our long-term decisions for these patients. And what's about pulmonary resistance in Fontan patients? A lot of people are treating nowadays patients with sildenafil or bosentan. There are very weak recommendations worldwide. The German Society decided last year for recommendation, if you go for cath lab testing and find a transpulmonary gradient of above 6 millimeters of mercury or a calculated resistance more than 3 Wood units, this type of medication may make sense. One word to transposition of great arteries. Everybody will think that arterial switch operation is a gold standard today. If you look to the data, it's obvious that patients with arterial switch operation survive in a bigger number than mustard, for example. And the number of re-interventions is much more less than compared to atrial switch operations. But what we see in the last years that in adulthood we have to deal in some patients with ongoing dilation of the aortic root. It's like Marfan. If you look to the set values at the bottom of the slide, these are data from Holland, from Netherlands. The patients which were operated for dilated root had set scores of 6.3 in the mean, up to 12. So this we have to keep in mind. And tricuspid regurgitation we see very commonly in congenital heart disease. This is maybe due to native tricuspid valve dysfunction, but more often it's due to secondary lesion after different kind of complex surgeries. But with time, ventricular and supraventricular arrhythmias will occur. We will see progressive right ventricular dysfunction and failure, elevated central venous pressures, and multi-organ congestion like in Fontan patients. So tricuspid valve problems should be addressed in time. And what we can do in the cath lab is put valve in valves in tricuspid position aside to the surgical option. But what I found is a recently published situation. If the risk is very high for patients, this procedure, putting 2 valves in valve stents into the SVC and IVC, may be an option for patients with very high surgical or valve in tricuspid position procedures. So worldwide, heart teams are ongoing to treat this kind of patients, and the quality of life and happiness level of these patients is growing for this. And the conclusion is that we need for our adults with congenital heart disease, high-skilled heart teams in our centers. Problems should be expected early to avoid multi-organ failure. However, we have still to learn ourselves what everything can happen in these patients. For pregnancy planning, all aspects should be carefully addressed in advance. Catheter and hybrid valve replacement patients with congenital heart disease and bioprosthesis will become the new standard of care. Minimally invasive effective techniques allow the reduction of number of cardiac surgeries and are needed for lifetime, which are needed for lifetime in this patient. And there's still a great potential for advances in technology in these lesions. Thank you.
So this lecture is open for questions and comments. I'll start. Rainer, this is a great lecture. In the US, my experience is that as more and more patients grow to adulthood with congenital heart disease, there's simply not enough adult cardiologists with the expertise in managing congenital heart disease, and pediatric cardiologists are not trained to take care of the comorbidities like pregnancy. What is your experience? Can you make a comment in your country? You know, what are the ways that the government or the medical schools are going about trying to meet this need, to fit the problems in between the two specialties?
Yeah. It's a very good question, and maybe at the end another conclusion. In Europe, we are now certifying a lot of doctors to be allowed to do this kind of medicine. At this time in Germany, around 250 pediatric cardiologists are certified, but only around 80 adult cardiologists. And even if they are certified, they very often don't have these skills, what I have raised up here a bit. So it's very important that we are working in teams. Pediatric cardiologists and adult cardiologists, but also for surgical strategies, congenital surgeon with an adult cardiac surgeon.
Yeah, I agree. I think the certification is the mental is the mental part, but you also have to have the skills to do the procedures. Yeah. So I think teamwork is important. Any other questions, comments? Okay, well, thank you very much.
Okay, I would like to introduce our next speaker, Dr. Pavel Teplov from Federal Center of Cardiovascular Surgery, Krasnoyarsk, Russian Federation.
Dear Chairman, dear colleagues, it's a great pleasure for me to report my presentation, Hybrid Approach for Right Ventricle Outflow Tract Obstruction in Infant with Multiple Malformations. No any disclosure of interest. Gradually increasing number of preterm newborns with critical congenital heart diseases and our multiple congenital comorbidities requires a complex team approach to managing such cohort of patients. Today, baby with critical congenital heart disease need minimum 6 medical specialists, excluding medical staff. Classic method for increase blood flow at patients with right ventricle outflow tract obstruction are systemic to pulmonary shunts and endovascular stent implantation. Hybrid stenting procedure for right ventricle outflow tract is one of the alternative palliation to increase pulmonary blood flow for critically ill with multiple congenital comorbidities. In-hospital criteria for candidacy for hybrid stenting procedure are preterm neonate with low birth weight, complex comorbidities, increasing risk of operation on bypass. It is necrolizing enterocolitis, intraventricular hemorrhage, active infection process, including sepsis. It is difficult vascular access, and we hear in previously presentation, it's very important problem in children. And genetic syndrome with poor prognosis for life. For example, it's Miller-Dickens syndrome and Edwards syndrome, et al. In our experience, during 2030-2070, we choose hybrid strategy and stenting 9 patients with critical obstruction of right ventricle outflow tract and heart comorbidities as most perspective for this group of patients. In this group, including 3 preterm neonates, 3 low-weight neonates, 2 neonates with genetic syndrome with poor prognosis for life, and 1 patient with kidney disease. This patient, number 4 in table, had hypertrophic cardiomyopathy with critical right ventricle outflow tract obstruction. Also, patient had congenital severe renal dysfunction and chronic proteinopathy. We choose this tactic as only way for help him. 3 patients with tetralogy of the Fallot, 4 patients with pulmonary atresia with ventricular septal defect, and 1 with single ventricle and critic pulmonary stenosis. 8 patients had low oxygen level and 6 of them needed vasopressin infusion. 5 patients had previous operation not connected with cardiovascular system, and the very important point was infection process in most of them. Surgical access was median stenotomy, right lobe thymus resection, and the pericardiotomy. We use epicardial ventricular electrode for fatal rhythm abnormalities prevention. On ventricular free wall, we placed pure string suture and punctured right ventricle. Next step was sheath placement into the right ventricle, fixation him pure string suture, and the orientation to the pulmonary artery. We performed contrast ejection through the sheath placed in right ventricle outflow tract. In this video, we see wire went from VSD to the aorta for orientation. And next step, we took another wire, placed it in pulmonary artery, into the right pulmonary artery in this case. In case of pulmonary atresia, perforation of the membrane was performed with obtuse needle from PTCI set under direct and TE control. To my regret, we don't make any records of this process. Next step was balloon pre-dilatation of pulmonary valve. The diameter of the balloon was chosen after pulmonary valve was measured on OFTE. And after control injection, the measure of pulmonary artery diameter and the length of right ventricle outflow tract and pulmonary artery. We use only bare metal stent. Stent selection is based on pulmonary artery diameter plus 1 millimeter and length right ventricle outflow tract plus pulmonary artery. We use very different stent. Stent implantation into the right ventricle outflow tract position. the stent should be positioned to cover all right ventricle outflow tract to avoid subvalvular stenosis. And angiopulmonography after stenting. In this case, we see good pulmonary blood flow, and we should see increased saturation at monitor. We try to use double control of stent implanting and functional in all cases, angiography and TE. But in some cases, dual control is not possible. In one case, we didn't use contrast agent because patient has severe renal dysfunction due to congenital both kidneys malformation. All steps of the procedure were performed under TE guidance only. We see revision of right ventricle outflow tract and pulmonary artery, balloon pre-dilatation, and the control TE after stenting. In this case, we had stent dislocation into the right ventricle outflow tract and used stent-by-stent technology. We've got a good result. And in one case, TE wasn't possible to do because of esophagus atresia. Always we must have plan B if we can't perforate the membrane. In this situation, we can stent PDA via right ventricle, VSD, and ascending aorta. In this case, after stenting PDA, we have stenosis stent, and we made balloon dilatation of this stenosis. After this, we had good pulmonary blood flow. All hybrid procedure were extremely effective in operation room, with gain in oxygen saturation ranged to 84 to 100%. One hospital death on second day after operation, patient developed low cardiac output syndrome with CPI and required ECMO. She dies after 10 days from polyorgan dysfunction and sepsis. All our patients were transferred to our clinic for prolonged treatments. In follow-up, 3 patients had second palliation stage. One was restented with BG stent after 4 months, and 2 MBT shunt was created after 2 months because patient had desaturation. In one of the patients, we tried restenting, but can position wire into the pulmonary artery across stent. We have 3 late deaths, one from abdominal catastrophe on 4 months after operation, and 2 from genetic syndrome. We can enlargement our right ventricle outflow tract and improve pulmonary blood flow, but can change genotype and improve prognosis. 2 patients today had full correction with good result, and 2 patients awaiting operation now. The hybrid approach for right ventricle outflow tract obstruction is an alternative option for critically ill newborns with multiple congenital malformations, which may allow them to survive till full correction of the congenital heart disease. Hybrid procedure may use it with lower risk compared with open heart surgery. And hybrid procedure gives a time for future treatment, our congenital anomalies, and preparing for complex open heart surgery. Thank you.
Okay, thank you for your very good presentation. I have one question. Do you have a hybrid operating room in your center, or did you perform this operation in cath lab?
We haven't hybrid operation in our center, and we use it cath lab for our procedure.
So, Uli?
Thank you for presentation. And I have a question. Do you have any case of fracture of stents located on right ventricular outflow tract or occlusion in this area of stents?
No, we haven't occlusion stent. All stent is work in all follow-up, but we have desaturation of this patient from 2 months in patient where we use small stent. We use the 3 millimeter stent or lower.
So no fracture, and we didn't any rehabilitation after of stent, no?
We try and lead dilatation stent in 2 cases. In 1 case, we finally we stent BG stent. We stent 3 millimeters and stenting 5 millimeter stent in 4 months after.
Thank you.
And 1 case we can't make this procedure because can't position wire across stent.
I have a question. How do you decide which patient to go to the hybrid procedure and which patients to do it in the cath lab without hybrid? Like, what's the weight criteria? How do you decide which patients to go one way or the other?
Very good questions. We all time we discuss all patients in our clinic, and if we see children with many comorbidities with infection process, we try to make hybrid approach from endovascular stenting, because when we make endovascular stenting, we have 2 problems. We have problem with central vein thrombosis after, and we have problem with heart rhythm in traction and right ventricle wire.
Because I would think that patients with comorbidities or with infection, they're probably safer in the cath lab with less cutting. You know, when we do the hybrid in single ventricles, the Norwood-Sano procedure, Sano obstruction is fairly common, and they're very small kids too, and we just do this in the cath lab.
Yes, Sano, yes, but infection process is bad for bypass operation, and Sano shouldn't technical problem without bypass. And now we stand in an enlargement stent. We try to stand 4 millimeters, 5 millimeters. It's diameter Sano shunt. And if we take BG stent and the late stent and the stent in all right ventricle outflow tract and haven't subvalvular stenosis, we see good result in few months with no desaturation, with no ventricular dysfunction.
Comments? Okay, thank you very much. Okay, our next presenter is Arnt Fian, is that right? And the topic is pediatric heart transplant.
I have no disclosure except that I'm not Arnt Fiana. I'm here to present his case. He couldn't make it. So I'm Tom Hoel at the top of the list here. Thank you for inviting me to beautiful Astana. I represent Norway. It's a very small country, and we have a population of 5 million inhabitants and only 1 transplant center. And our transplant program is shown here. We started up in 1983, and now we do about 70 transplants a year, intrathoracic transplants. The survival curves of all of our transplants are as shown here, and compared to the ISHLT's list, they are very good. I want to pay a tribute to the guy in the middle here. That's Leonard Bailey, who actually is one of the pioneers in pediatric heart transplantation. Last year when we did this material, we had done 54. We have now 3 more pediatric transplants. That means we do between 0 and 5 a year. The mean age was 10.8 years. 44 out of 54 then were alive. 7 were under the age of 3 years old. 6 from ECMO, 3 from LVADs. We had population of switches, Rastellis, congenital corrected transposition, Fontans in there. We'll look into the material in further detail. The gender distribution was as follows. 2/3 of the patients were actually boys. The diagnosis of the recipient was dilated cardiomyopathy in most of the cases. Only 1/3 of the patients had congenital heart disease, and 3% was retransplantation, and there was some other rare cases. 3/4 of the patients were transplanted without any circulatory support in advance, but those on support, they were 10% on LVADs, 12% on ECMOs, and some on IABP and Impella. 8% needed ECMO support postoperatively, and some needed RVAD support. The age distribution of recipients is interesting. We have 8 patients between 1 and 5 years old, as you can see at the bottom. 13 between 5 and 9, 13 between 9 and 13, and 30 below, between 13 and 18. And we have no donors available for the age group below 1 year of age. We have looked at the material into further detail by looking at survival curves. Mean survival after transplantation, if you look at the curve, it's 50% are still alive, 24.2 years out for males and 19.3 years for girls. That means there's actually no difference between those two groups because the numbers are so small. If you look at recipient age, there is a tendency that the smaller kids have a worse outcome, but still not significant. If you look at patients by preoperative circulatory support, it's a well-known fact that transplantation from ECMO is a bad thing, and if we have looked into that, but we do not find any significance in survival. That's mainly because the numbers are too small to actually achieve that. I believe that in every paper from the pediatric heart transplant study shows that ECMO is a very large risk factor regarding death. If you look at diagnosis, congenital heart disease, dilated cardiomyopathy, or retransplantation, the retransplantation is only 2 dots there, so that doesn't make up any difference at all, so that there's no significance in survival. If you look at survival by donor age, there is a tendency that the smallest donors tend to live shorter. The ischemia times are quite short anyhow, so there's no difference there either. Most of our patients are still put on cyclosporin as a calcineurin inhibitor. From the ISHLT data, we see that most patients are put on tacrolimus, and regarding the antiproliferative agents, all patients now receive MMF. Azathioprine was used in the beginning in the 80s. We usually did not use induction therapy, but now we have started using IL-2 receptor antagonist, Simulect, as our induction therapy. And if you look at survival by induction therapy, I think the survival curve can be explained by the fact that ATG was used just on indication for high PRAs or immunological problems. And most of the patients in the earlier area had no induction, and now we use Simulect, and that's the newer era. I think the difference in this curve is actually a time attributed to the time factor. no rejection episodes, 1 and 2 episodes does not seem to make any difference. If you have more episodes, probably if the material was larger would be significant. No, regarding the donor cause of death, no differences in survival. So I want to conclude that pediatric heart transplantation is feasible with good result, at least short term. The question is, however, who should we transplant or who should we not transplant? The limiting factor is organ availability. And in our country and most of Western Europe, I think there are very limited number of organs available under the age of 1 year. Thank you.
Any comments and questions from the audience?
Thank you very much for a great presentation. I have one question. So you show that you have used circulatory support before transplantation. In which cases did you use Impella?
Rather stable patients above the age of 15, staying in the ICU, but not able to wean from a balloon pump or an Impella.
Thank you very much.
Okay. Well, since you're going to speak again, I'm going to have you go on to the next lecture. And this next lecture is on the topic of transplants.
Okay, just waiting for my slides. Next slide. Okay, so from the same group, we have looked at retransplantation of hearts, and this is not only in children, because we have done in our program, our program is larger than 850 heart transplantation. So there are only 25 retransplantations. That's 2.9% of the whole material, and just 2 of them are in kids or children below the age of 18. So if you look at the gender distribution, we have on the left side the gender distribution of the pediatric transplant program, and even more males are transplanted in the retransplantations group. The age distribution of the first transplant is depicted on the 25 patients is depicted on the left, and of course everything is shifted towards the right, and we will have a closer look at how long it will take before they are retransplanted. The diagnosis at the time of first transplantation was ischemic cardiomyopathy in 37%, dilated cardiomyopathy in 38%, and other diseases, including several with congenital heart defects. The question of panel-reactive antibodies is a great issue when doing retransplants. And if you look at this, quite few of our patients actually develop PRA. The figure on the left is before the first transplant, and on the right before the second transplant. We can see that 4% develop PRA of 10%, 12% PRA of 20%, 4% PRA of 40%, and one patient who was actually transplanted long ago had no pan-reactive antibodies on retransplantation. Strange, but that's what the figures say. One patient was on ECMO pre-transplant, 3 patients could not be weaned off heart-lung machine postoperatively and required ECMO support. Still, we use cyclosporine as our main CNI agent, and today all of the patients receive MMF, so this is due to a time shift more than policy. Almost all patients today receive basiliximab or IL-2 receptor antagonist as induction. If you look at coronary allograft vasculopathy, that's the main reason for retransplantation. 3 patients were retransplanted for rejection and 4 for primary graft failure. Time from first till second heart transplant. If you look at the survival curves, you see that the mean is 11.9 years out from the first to the second transplant. If you look at the survival curves of adolescents from the former presentation, the 50% survival there was out at 23.2 years. And after retransplantation, the mean survival, 50% are dead 11.2 years out. And that's, of course, much worse than the primary transplant. If we stratify by induction therapy, we see that the curve here in blue is those who got none. The green was ATG, and basiliximab is the last curve at the top. And it seems like it's doing better with a significant difference. We did survival analysis and stratified for all of the parameters as well, but the numbers are too small to make any conclusions. There's a lot of curves. So I want to conclude that from a technical point of view, the retransplantation is not much different from a redistributomy. Whether retransplant should be performed is still being debated. Could the organs go to someone who has a longer probability of survival? Retransplant candidates should meet the usual criteria for the first-time recipients, and the results are good when performed electively for coronary allograft vasculopathy. And from the International Society of Heart Transplantation's database, we know that when transplanted for ECMO, the results are much worse. Thank you.
I actually have a question on surveillance biopsies. We know that at the beginning, we do a lot of biopsies and then it slows down later on. Are there any new ideas going about that can help to determine rejection without having to do biopsies? It seems such an invasive, repeated procedure.
Everyone try to look into that and find new ways, and they do sophisticated echocardiographic examinations with the tissue velocity analysis and so on. I don't know how good they are at the time being, and there are also companies doing gene analysis. So you can take a blood sample and look for amplification of some genes as a marker of rejection, but I think that work is still in progress, and I don't know whether it's going to take over for routine biopsies. We do a lot of them.
I agree. That's still the gold standard right now, but it just seems such an invasive, repeated procedure.
It is.
The second question is on the coronary angiography. Sometimes those changes are very subtle, and there have been times where I would take a picture and say, "Oh, that looks very good," and of course, down the line, the patient has the coronary arteriopathy. Do you have any tips or comments on how to assess the coronaries in a better way?
No, I haven't, because these subtle changes, they suddenly appear many years out and often without symptoms. So it's, I think, routine angiography is the only way to find them, I think, at least early.
Okay, thank you very much.
I would like to introduce our last speaker for today. Her name is Einat Birk. She works in Schneider Clinic in Petah Tikva. In my opinion, she is #1 in pediatric cardiology in Israel.
Well, thank you very much. I'm delighted to be here again, and more delighted to see the major difference in your institution. This is quite striking to see the difference between the two visits. So I'm going to talk about decision-making with Fontan fenestration. And in fact, as several speakers outlined today, Fontan is a compromised circulation. You hear me? It's okay. We continue to learn about the long-term effects of this physiology. Now, the most common method to complete Fontan today is to have some form of TCPC. I think most places do now the extracardiac Fontan using some type of conduit, usually Gore-Tex conduit. Now, the decision to fenestrate all patients, none of the patients or some patients remains controversial, and I think it changes quite significantly from one center to another. Now, I'm not going to go into the debate, but I am going to say a couple words about why to fenestrate. Well, the physiologic basis for the acute benefit of a fenestration are to increase the ventricular preload and therefore to increase the cardiac output. We are also trying to lower the systemic venous pressure, i.e. the Fontan pressure. What price do we pay? Well, there is virtually right to left shunting, and we pay the price of cyanosis. Now, fenestration may lead to a decrease in morbidity and mortality in the immediate post-op period. Again, this is debatable, but there is quite a significant body of evidence that these patients stay in the hospital for a shorter time and the duration of the effusions is reduced. Now, what type of risks does a fenestration carry? Well, there are early risks and some later risks. There are some reports that due to the obligatory right to left shunting, these patients may suffer embolic CVA, and all of them have a higher intervention rate as time goes by. Now, left fenestration effects are associated with exercise capacity and aerobic reserve, which are probably reduced and can improve after fenestration closure. Ventilatory response to exercise improves after late closure as well. Now, those phenomena are not seen early on during the post-Fontan course. So if we summarize, the benefit of fenestration are probably hemodynamics, probably less effusion, probably decreased mortality, though there are many centers right now that are not doing fenestrations and show identical mortality rates, which are low in both groups. The risks we carry are the right to left shunting, leading to cyanosis with all its carried complications, associated complications, possible embolism, need for repeated intervention, and reduced aerobic capacity. So, what can we do? Well, we can assess our patients whether they're suitable for transcatheter closure of the fenestration. In order to do so, we do a complete right and left heart catheterization, and as people outlined earlier today, we are trying to fix all possible soft points which are fixable. So for example, if we see some coarctation, even if it's mild, we stent it. If we see some branch pulmonary artery stenosis, so we're trying to optimize the anatomy to allow this unusual circulation. Now, we finally, after doing a full assessment and treating whatever has to be treated, we close the fenestration, we balloon occlude the fenestration for 10 to 15 minutes, and we remeasure the various parameters such as saturation, pressures, etc. Now, there are several studies, actually there aren't many studies about it, but there are several studies from the past who are outlining what happens or what is expected to happen when we close a fenestration. You can see that most people show that CVP goes up or Fontan pressure goes up. The saturation is increased, that's why we want to close the fenestration. Cardiac index goes down, and oxygen delivery actually goes down when we close the fenestration. So in order to make this decision, we have to prove that when we close a fenestration, the hemodynamics that we find is acceptable and allows us to close the fenestration. So this is actually the word modest that you see on the top. If systemic O2 is improved with only modest fall in cardiac output and rise in Fontan pressure, is copied from the current guidelines. So there aren't really strict guidelines or clear guidelines of how to make the decision. But based on all the former studies that I outlined on the previous slide, non-acceptable hemodynamics are when we see a decrease in the cardiac index of 30 to 35%, or in absolute numbers less than 1.9 liter per minute per meter square, or we see increased systemic venous pressure of above 17. If those are seen while we occlude the fenestration, we usually do not close the fenestration. Now, there are numerous techniques to do it and a wide variety of devices. I will show you one case. So on the left, you see a lateral projection of an injection in an extracardiac fenestrated fontan. And on the right, you see balloon occlusion of the fenestration. We always verify both with angio and with or with TEE that the fenestration is indeed closed. So after doing so, we remeasure all the parameters. All of those procedures involve using TE. What you can see here is the fenestration. The lateral tunnel is actually on the right. This is a patient with tricuspid atresia, and the blue flow is a flow across the fenestration, quite easy to see on TE. Now here comes the wire which goes across the fenestration, and following the wire you can see the device. You see some trickle of contrast across the device, and you can easily see that the left disc is on the systemic side and the right disc is on inside the fontan circulation. This is how it looks on angio, and you see that the fenestration is practically closed. It's always intriguing to see that contrast echo is much more sensitive, and this is the same patient, same injection as you see on ultrasound, and you see that there is little bubbles going across the device. This usually goes away within a few days. So we looked at our experience from 2009 to 2014. We had 41 patients who did not receive pulmonary vasodilators. I will elaborate on that coming up. This is information we just presented in Barcelona in the European Congress. I'm not going to go into all the numbers, but we actually found exactly what we saw in the world literature. So when we balloon occlude the fenestration, the mean cardiac output goes down. We found the mean decline was quite significant, with a p-value less than 0.05, and the numbers are significant from 3.8 to 2.1 liter per meter square. Now, 36 of our patients underwent fenestration closure because they were found suitable hemodynamically for fenestration closure. We identified 5 high-risk patients whom we treated with pulmonary vasodilators, either sildenafil or bosentan, and we did not have a systematic way to decide which drug to use. We just used it for various reasons. We then repeated the catheterization 6 to 9 months later. And what we found was quite interesting. Now remember, those are the same patients, and that's why, in spite of the small group, we can get significant numbers. The most intriguing thing was that the cardiac output following balloon occlusion, fenestration occlusion, was significantly higher in the treated group, and the decline in cardiac output following following balloon occlusion went from 36% to 9%. And again, with such a small group, we can get very impressive numbers because the patient is his own control. So it's a paired test. So if we look at the number, 36 of the 41 underwent initial closure. 5 patients which were identified as high risk were treated for 6 to 9 months with pulmonary vasodilators and then underwent fenestration closure. Now we have midterm results of follow-up, mean follow-up of 3.6 years. All of them were functional class 1 or 2 and all had saturation of above 92%. So what can we say about this issue? We can say that fenestration closure in the cath lab is safe, routine procedure. We may be able to say that chronic pulmonary vasodilators in high-risk patients blunted the decrease in cardiac index during the occlusion of fenestration. Now, we can't tell how it happens, but we may speculate that there is an improved pulmonary circulation in the sense that it's able to accommodate an increased flow. And I would like to leave you with a question which echoes what Reynard just said an hour ago. Should all Fontan patients be candidates for management with pulmonary vasodilators? Before, after surgery, before fenestration closure, after, I don't know. I mean, there is very scant literature about it, and I don't think the verdict is out. Now, I would like to leave you with, since I'm the last speaker, I'm going beyond the topic, and I'd like to show you a case that we did a couple weeks ago of a 6-year-old with very complex heart disease, situs inversus, AV discordance, VSD, which did not allow biventricular repair, double outlet right ventricle, and complex PS. Now, this kid underwent fenestrated extracardiac Fontan with a DDD pacemaker in the beginning of 2015. He was fenestrated initially, but the fenestration closed spontaneously, which happens, according to the literature, in about 20–30% of the cases. Now, at the end of 2015, he developed PLE. He started all the usual meds for PLE with very, very little response. Now, we cast him several times. We actually had a good Fontan, so anatomically we couldn't help much, and the medications didn't seem to do much. Now, his most recent cath, as I said, was a couple of weeks ago, where the Fontan pressure was only 14 and the pulmonary wedge was 7. Now, this patient, you know, we stand there and we say we wished he had a fenestration. Now, the question is what to do. You know, PLE patients are quite sick. This is a very difficult group to care for. They are very symptomatic. And here is what we did. So here is his extracardiac Fontan. The pulmonary arteries are very reasonable. We don't see any technical thing that we can correct, and we do not see any fenestration. On ultrasound, I don't have a pointer, but on the right of the screen, remember his situs inversus, you just saw it on the angio, you see the extracardiac Fontan, you see the 2 AV valves, and you see the area which would be the target for fenestration creation. So here it's labeled, you can see it better. The Fontan is on the right hand of the screen, and we see the natural place to create a fenestration. And indeed, this is what we did. You see the needle crossing the Fontan into the atrium. You see the contrast in the systemic atrium. And this is how it looks on the angio. You can see the puncturing needle. I have to say that ultrasound usually is a great aid in a situation like that. You feel much, much safer. You know where you are. And here comes a Bentley covered stent, 6 millimeters in diameter, and you can see it passed across the wire, inflated in position, right here. And you can see the fenestration working at the end of the procedure. You see the flow across the stent, which is functioning immediately as you put it in place. This is how it looks on echo. So you see again the fontan, you see the stent, and you see the blue flow across the stent. Now, clinically, the patient improved quite. We were struck. Obviously, his saturation went down. He was in the 90s. His saturation went down to the 80s. Pressure didn't change much, but within 2 days, his ascites almost disappeared, and his hemoglobin, for the first time in a year, rose to 3.5 from about 2.5 throughout the year before. And obviously, you can not do such work as the one I presented without a very cohesive, strong team. I'm very lucky to have some of my friends and colleagues here. We always have our surgical colleagues support us. We have strong anesthesia support, and which we use all the time. We have ICU people. And we have a big and enthusiastic cardiology team. So I thank you for the opportunity.
Thank you very much for your visit again. We are so happy to see you here in our clinic and in our country. Thank you very much. And I have only one question. About 6 patients which was in high risk for fenestration closure, and you treat them with vasodilator and after that closed. After closure, did you stop medication or they continue to receive them?
We continue to give them, yeah, we are, you know, it's not evidence-based, but common sense says, you know, those are marginal patients and we would like to do anything we can in order to keep the resistance as low as possible.
Thank you. And another one question. Your own strategy about pre-fontan treatment of patients. Do you receive sildenafil before fontan procedure or not?
It's a very good question, and I'm not sure, again, that we know what to do. We don't routinely use pulmonary vasodilators before fontan. We do use it in marginal cases. However, as I said, I don't think the verdict is out, and it might be an interesting thought to do it in more patients before surgery.
Thank you.
Well, thank you. This was a very thoughtful talk, and I really liked your last a quote that we have to create the future and not waiting. But sometimes we have to go back to the future. And what I think what we are missing in all our discussions these days, I mean, we discuss how to make a fontan better. Personally, you know, having been very optimistic for my first 100 fontans, which I had done by 1995, and there were even like 5 fontans in the first year of life, because I just thought I could do it, and it really worked. And Pascal Vouhet in Paris, he started already a different track. They said the fontan is not a good idea, you know, to stop, you know, there are all, you know, he was kind of foreseeing some of these problems we discuss about now. I personally feel when we have somebody like a high-risk fontan, there should not be a high-risk fontan. If you have a high-risk fontan, forget about it, unless you really have severe cyanosis. So you have one of your early slides says like the risks and benefits of not fenestrated, fenestrated, and I think you should maybe redo the whole thing about, you know, leave it at the Glenn state.
Yeah.
You know, and you see, I just remember when you said like fenestrated, you had like, you know, 4 risks still. When you do not fenestrate, you have only 2.
I
namely
fully
the
agree
cyanosis
with you.
and the potential, and the patients, you can leave patients at 85, and you have so many patients. I'm not saying that you should not do a fontan. I mean, we still like it's a great operation and patients benefit, but now being at a certain age, seeing all my patients, you know, 25 years, even 30 years, I mean, yeah, I've now more than 30 years where I did Fontaines, and so many died. I had an 18-year-old die of liver carcinoma at 18 years after Fontaine. So you rethink. And I just would like to put on, there was a quote of Jim Locke when all the dilatation started. He said, now that we can dilate, should we always dilate? And I would say, just because a patient meets the criteria for a Fontaine operation, does this mean we have to do a Fontaine? And forget even about the high-risk Fontaine with sildenafil, because we have all these medications. So I think we should rethink, and the liver is the problem. 10 years after Fontaine, we see already changes in the liver structure in more than 30% of the patients. So we create a lot of additional disease. Again, I think some patients, and there is a 20-year follow-up of Pascal Bohet. He wanted to avoid Fontaine at all, and he failed in this. But he at least has in his series like a mean age of Fontaine around more than 9 years. And I think the moment we do a Fontaine, fenestrated or not, we start the clock on asking for problems. And maybe if we can avoid this starting the clock, we may be better. Frank, you may know in the United States, if a surgeon tells this guy like me, the cardiologist send him to the next surgeon. So if you do not operate, somebody else will operate. But I would like to start this discussion. Fontaine is a great operation, but we may have to be a little bit more reluctant and not put it on every patient, and for sure not on the high-risk patient.
You bring up some good points, and we often have very intense discussions at our conferences. Von Starnes is a very aggressive surgeon, and I think that we tend to probably take on more complicated single ventricles and push them through Fontaines. Again, a lot of medical management afterwards. I do agree. I don't know what the right answer is. I guess one way to think about it is that what other alternatives do we have? If we're going to send them for a transplant, that's another, kettle of worms. You can leave them in the Glenn stage, but that in itself is not the best either. So I don't have a good answer. I don't know whether even a high-risk Fontaine now is still the best option that we have at this point. It's interesting, we started doing Fontaine surveillance, a protocol now, for all the kids after 10 years of age. And I think you're right. We're beginning to see a lot more liver problems, things that we didn't expect before. So nowadays, we've tended to, again, not evidence-based yet, but we've tended to put everybody on sildenafil, especially after their surveillance protocols, just to see whether that can help in any way.
They feel better.
Yeah, so we've been doing it pretty aggressively now.
I mean, I do not want to abandon the Fontaine operation, but giving this, we have shown this with the Glenn and an additional pulmonary blood flow. You easily achieve saturations between 85 and 90. This set of patients, if you have, he has great pulmonary pressure, he has a great low pulmonary pressure, obviously, he has a good anti-systolic function, but he has a saturation between 85 and 90, and he is 4 years old. Why does he need a Fontaine?
It's a very good question. There are several issues about it. One, kids tend to get more and more cyanotic with time. However, Fontaine is a ticking clock, like you said. It's a ticking bomb. So there are not, there are at least few cardiologists that I know, including in the States, north of LA, who elect to do Fontaines a bit later. So if you set a bomb, let's set it later. This is one answer. But the issue is that I'm sure there is a window of opportunity to do it, and if you wait too long, you're paying another price. And kids are becoming more cyanotic. I'm sure you have some effects on the contractility and diastolic ability of the ventricles. So there is a window of opportunity. Now, there is an old paper from LA by Hila Lax looking at Glenn plus additional pulmonary blood source. And the results are quite good. So this is in support of what you suggested before. I mean, this is definitely an option. And I don't think this issue is solved. I don't think that we know what's the best.
Yeah. I mean, first of all, if you say like the Glen and additional blood flow, obviously single ventricle and especially complex single ventricle is not good news. I mean, we have to make the best of it. And the question is, you know, what may be the best? I do not have the answer. I was like, when Pascal Bouhet came, we shouldn't do Fontaine. I said, oh, you just cannot do it. We do it at 1-year-olds and it works. But now you see it after 20 years and you never get too old to learn. I'm not coming on and saying, I never would do a Fontaine again. Sure, we'll do Fontaines. You know, and when they really get cyanotic and their daily lives get compromised. But just let's start with a subgroup, you know, the 4-year-old, 85% saturation, you know, good functions, just watch him. I'm not asking you to make him like 75% saturation and then start him. But they may do very well for a long time. And for sure, the liver will love it. You know, and the liver will start. And you may get, now you have after Fontaine, let's say like 20, 25 years when the liver really gets a problem. I mean, forget about all these PLEs. But when you do your Fontaine 6 or 8 years later in good state, you will get 25 plus 8 or plus X even, because you know how the liver will react later. I mean, this is what we do not know. Yep. I still want every kid to be happy, even with a single ventricle, but there are a lot we do not make happy fun.
This was a great discussion. I think the last lecture on your program was canceled, so this concludes our session. Thank you for your attention.
Тогда там because you put it in